I have the pleasure of announcing the next session, which is again another very engaging session on enhancing health systems resilience, this time in the context of conflicts and mass displacement. We have Dr. Sohail Saikat joining us virtually to deliver the keynote session address. Again, this session is divided into a keynote and a panel. Dr. Sohail Saikat serves as the Senior Advisor and Lead Health Systems Resilience and the EPHF's World Organization and has expertise in integrated systems strengthening. I request our very own Dr. Hala Zaid to deliver the highlights from the lead-up session in Cairo by way of introducing Dr. Hala, who's already been introduced before. She currently serves as our regional director at the MENA office and has been Egypt's Minister of Health and Population, spearheading the country's successful Hep C elimination program and launching universal health coverage. May I have you on the desk, Dr. Hala? Sohail, I have kept you waiting, for which I'm very apologetic. And thank you.
Thanks a lot. Let me project my screen just a second. Can you see my screen? Let me.
Yes, we're all right there with you. Sohail, it is so sad that you're not here in person with us this time.
Apologies, Oma. It's because of the context that we are in
I
now.
I know.
Is it now
Full
in a
screen? Yes,
presentation
you're
mode?
all set, Sohail.
So colleagues, thanks a lot and thanks for the leadership of Access International and also my very selfless colleague, Dr. Krishna Reddy, for again convening this group. I think something very close to what we do from WHO headquartered in Geneva, building resilience in health systems, something not transactional, something more organic, something more longer term. So not an easy pathways that we both are intertwined. So the focus in my presentation, I think, is going to be more about countries in FCB context. Traditionally, I speak more about countries in normalcy, but this is an area first time I'm speaking to your group today. So this is a global perspective. As you could see, we have around 8.2 population that we are sharing the earth that we are in. And then quarter of the populations are living in countries with FCB context. So is the FCB, as you know, is the fragility, conflict and violence affected setting because of very low level institutional and governance capacity. So which is a very, very conducive, I think, for war and conflict. So this is not a regional issue, as you could see from here, is a global issue when it affects around 1.6 to 2 billion people that we have. And although there are many perceptions, as you know, during from the media as well as from politicians, but unfortunately, majority of these people who are affected, who are displaced, they are in low and middle income country setting. So a huge epidemiological and health systems challenges, I think, to provide services to this population. This is a same but in a geographical representations of countries affected by fragility, conflict, and violence. And then on the right-hand side, you could see the countries affected more acutely by climate stressor. As you could see, there is a overall consistency that FCBs are part of those countries that are also prone to climate change. And the relationship, I think, is obvious. I think is an antagonistic, is a synergistic, is a confounding. So countries affected by climate change are more vulnerable to because of their fragility and conflict, because they have to share the same resources. So combined climate vulnerability and fragility impair social and economic outcome because the conditions worsen the poverty, hunger, and displacement. So further impeding economic and social development. Now trying to take the focus a little bit more on health aspect here. And on the left-hand side, you could see also the good correlation between global health security index and some of these FCB countries. So countries with FCB status are also have a very low capacity for health security. And then if you look at on the right-hand side, again, this group of countries, as well as globally, because we had COVID-19 and then we had war in Ukraine and then we had war in Middle East. At the same time, we know Sub-Saharan Africa affected by protracted conflict. So the global outlook, unfortunately, colleagues, is not very, very good from a SDG or USC point of view. 4.5 billion people still lack access to basic package of health services. 2 billion people suffer from financial hardship to get quality health services. And 1.3 billion have to spend more than 10% of their household income to get the medical care. So quite a bleak scenarios, but more profound in countries that are affected by fragility, conflict, and violence. So this is on top of more than 50 countries globally. Many of them are also part of FCV. They do not have adequate health systems foundations. For example, number of health workforce, supply chain, supply of medicines, robust information systems. So they are absent. And I know that in many countries, health workforce are not paid from 6 months to a year. There are many countries, basic IPC provision, basic running water, electricity are not there. So that is not insignificant. I think it's more than 50 countries that are lacking in very, very basic foundations for health systems to operate. And then I think it's not surprising, as you could see from this figure, about the relationship between countries with FCB context and maternal mortality. So they all have highest burden of preventable disease in terms of maternal death, in terms of under 5 mortalities, as well as the neonatal deaths. So not an unsurprising, but this is the reality that we are in. So this is another picture, I think, where we are now, because if you look at countries in FCB context or in humanitarian response, so they operate under humanitarian response planning. And there are, I think until now, there has been a significant support from international organizations, bank, development partners as a humanitarian assistance. But the issue is that there is a lot of fragmentations, whether you could say humanitarian response plan to IHR related or global health security related, various investment and planning, as well as vertical disease program we have, as well as traditional way of strengthening the system. Unfortunately, if you closely look at the purpose of those investment is very much transactional. Is that okay? I'm giving 100 million. What it will entail? Yes, they entail vaccination, they entail life-saving services. But unfortunately, there is a missed opportunity to bring them together as well as to guide some of this investment to build longer term baseline health systems capacities. So given that they do not speak each other, parallel, often fragmented, and always time bound, looking for something to report back to the taxpayer. So some of the foundational aspect in health workforce, in infrastructure, in policy and planning still remain very, very weak in majority countries. So this is something colleagues will lead from Geneva, Office of WHO on building resilience in health systems. And so we have a body of work in public domain, and again galvanizing the work that Access International and many other knowledge authorities have been doing over many, many years. So if you look at the three buckets, so in the three buckets here, it needs some intentional actions during the time of normalcy, during the routine context of health systems. And then it also asking health system not to just stay as it is, absorb and just not to do anything, but it asking to maintain services to the individual and communities. And it also asking health systems to learn, recover, and improve so that we can better perform in a future shock events. So two major aspects here is that resilience of health system is not just limited to emergency context. We have to have the intentional input during peacetime, during the period of normalcy. Otherwise, it will not, we cannot expect the system to perform well when shock happens. Think about colleagues COVID-19. It was quite an expensive operation. Financially expensive, prohibitive. Population health point of view, it was a tragedy. Around 6.7 million people died, with 14 to 17 million modeled as an excess mortality. So we need to do things differently. This is all about resilience of health systems. Now, if we look at those countries that we know, not very far from where you are now, not very far from where I am located now. So we cannot just let the situation to impact on the people who are affected. So first humanitarian principle, or first any principle of us as a human, is to maintain vital, essential health services for the affected communities. So there are some good examples. I think in Ukraine, in Iraq, I think they managed to assemble modular primary care clinic to provide the primary care and public health functions and services. And there is also a huge innovation now on telemedicine, and it has been applied countries in Middle East and North Africa. So they provide diagnostic and consultation despite geographical barriers. I think when you do not have proper secondary, tertiary level referral system, this is the basic that we can expect to do with humanitarian partners, WHO and national authorities, or even sometimes with non-state actors that normally operate countries in FCB context. Second one, we do not do it often, but it should need to be institutionalized, is to do proper health service continuity planning in affected facilities as well as the facilities that are likely to take in migrant and refugees, i.e. displaced population, as well as the neighboring countries to proactively consider service continuity aspect so that you know what is your capacity, you could know what are the most vulnerable people, how could you serve them, how could you transfer some of the patients to the nearby facilities that are not affected. So some of this proactive planning, there are many examples that can allow to save lives. At the same time, better utilization of the resources that are often very, very scarce in those contexts. And we as a WHO had a very, very practical, easy handbook for every facilities that can apply to build their service continuity planning. The other major aspect, colleagues, as you know, we often talk about recovery. But if you think of COVID-19, we as a team had a special collection issue with 24 articles. I think the aim of that special collection issue with the journal is to look at the global understanding and global policy and practice, whether they embraced recovery from event like COVID-19. And unfortunately, as of now, it is not properly considered as a policy imperative. So we as a WHO came up with a handbook on how to plan a recovery from disruptive public health event, including countries that are in humanitarian response. I think if we do not factor in recovery, what will happen? I think is a common sense. Without recovery, we cannot go back to pre-event baseline. Sometimes it can go further deteriorate the baseline. But if we can factor in proper recovery planning, there is a better opportunity for a build back better, so that you know what is your capacity, what has been disrupted, and how can you ensure that some of the backlog of services, some of the disrupted infrastructure can be restored, can be rehabilitated. So very, very important even for countries with FCB setting. So the other thing, colleagues, I think you all came across this buzzword, humanitarian development, peace nexus. I think there are many references from UN bodies as well as from international partners. And we looked at all of them. And by working with our regional office, we came up with a dedicated framework how to embed health aspect in currently siloed humanitarian development peace nexus initiative. So in that framework, we applied pragmatism and simplicity. So there are 3 domains that you could see from the figure. We put, although it's not that linear, but we identified what are the actions needed under humanitarian response, development planning, and peace building, and how these actions focusing on health can be anchored in a national system, from health sector planning to health sector budgeting and financing, as well as in service delivery platform to monitoring and evaluation. And we also articulated the role of different stakeholders who can be critical to operationalize HDPN, focusing on health aspect. Just one example, colleagues, as you all know, probably I think you can also relate with your own country level experience from COVID or any other major disaster that you have. So what happens when disaster hits a country or when war and conflict broke out? We know that there is a humanitarian response planning with additional resources like mobile clinic, like additional health workforce, sometimes drained from the national health workforce, additional funding, etc. So what we are saying is that we have to have an inventory of the additional resources that have been mobilized during humanitarian response. And in the humanitarian response planning, we need to factor in how can we provide a handshake between humanitarian response planning and national planning process so that additional ambulance, additional health workforce, surplus of medicines can be orderly transitioned into national system so that there are not going to be a missed opportunity. There is going to be some accountability to provide that transition. And similarly, if we remain optimistic in those countries that situation is now stable, development is kicking in, peace is holding, what we could expect is that GDP will grow, human development will grow. So we would like to have a better dividend. Health sector needed to have the dividend of extra growth that we can expect in that country so that there can be additional resources to go into health systems from development and prosperity in a country. But it is not going to happen automatically unless we can factor in the national policy and planning process with regional and international partners. So colleagues, this is what we have as a WHO in terms of differentiated approach to country support, core predictable country presence. If you look at the spectrum here, and we have office in 150 countries. So depending on countries' health systems maturity, sometimes is policy support, sometimes is a various range of technical support. But countries in humanitarian context, I think WHO's mode of support is again to save the lives, is to provide the services for the most in need, most affected communities. So WHO is mindful that we also need to learn and contextualize our operations in those contexts. This is one example, colleagues, I think that I particularly worked with for a couple of years, very closely with my colleagues from Africa. So South Sudan. So we supported this country to come up with a stabilization and recovery plan. So we tried to look at what is the state of disrupted system in South Sudan, what are the critical gaps that we need to address, guide the investment to address them. At the same time, some of the cross systems issues that we also need to look at. Second, how can we build the confidence of the international partners on government and its other stakeholders from capital up to subnational level? Because ultimately, without government's buy-in, support to the government, I think this type of country could remain vulnerable to FCB context in many years ahead. So we had some experience in applying humanitarian development peace nexus, focusing on health in country like South Sudan. So my last slide, colleagues. So we can all relate to the current context in FCB countries with a shock number one. As you could see that, or you could relate this with our experience in COVID-19. We all know that services disrupted. We all know that the economic impact of COVID-19 as well as the countries that are affected by war and conflict. So this is clear, I think, from impact from health to cross-sectoral impact. So unless we put our resources, unless we guide the investment with intentional input to build resilience in those countries, in health system as well as in other allied sector, we cannot expect a different outcome in the next pandemic or next major shock event. But if we do work well, if we really commit to provide Build Back Better with resilience as a framing, I think what we can expect that in next shock event or next pandemic or next war and conflict, the impact, cross-sectoral impact as well as the impact on service coverage can be less than what they are experiencing now. If we do not do that, colleagues, I don't think we can be exempt that we as a health communities have played our part in the context that we are in. Thank you very much, Dr. Uma and colleagues. Back to you all.
Sohail, you always leave us in awe and short of words because of the homework that you do and the way you actually share in detail all that is going across the world right now. Thank you so much. I am, in the interest of time, going to call up the panel. Dr. Shaza Hani, Public Health Researcher and Manager, MENA Region, Access Health International, and manages the Hep C Alliance and the Public Health Initiatives. She will moderate the session. Dr. Ahmed El Subki, Chairman, the Board of Directors of the Egypt Health Authority, EHA, a position that he's held since 2020. And in this role, he has transformed initiatives aimed at enhancing healthcare services and accessibility in Egypt. Welcome back again. Professor Mala Rao, welcome back again. Hala, who's going to be here and who's also going to share her words of the round table along with her panel discussion. Joining us virtually are Dr. Ahmed Sada, Executive Director of the Civil Society Support Fund, Ministry of Social Solidarity, Egypt, a medical practitioner with profound experience and commitment to international development and emergency response. Welcome on board, Dr. Ahmed. We wish we could have had you here in person. And Mr. Jacob Arhem, Public Health Officer, United Nations High Commissioner for Refugees. He has 20 years of experience of humanitarian work as a physician, medical coordinator, and a public health officer. Welcome on board, and Shaza, all yours to take forward.
Thank you so much for sharing your upcoming insightful interventions for this panel discussion. Thank you. So I'll get directly into the questions because of the time constraint. I'll start by Dr. Hala Zayed, Her Excellency. as Egypt is increasingly serving as a hub for displaced populations. And it's very essential to explore how can we integrate healthcare services more effectively to cover the host community needs as well as the displaced populations. So what do you think, Your Excellency, are the innovative strategies that you think might secure seamlessly integrated healthcare services that cater for both the host communities and displaced communities?
Thank you. Good afternoon, everybody. And it's very hard to speak during fasting more than 15 hours without coffee, but it's okay. So before that, I would like to acknowledge the valuable insights shared during the Egypt session on health system resilience in conflict and mass displacement. And the hosting of Egypt Healthcare Authority under the leadership of Dr. Ahmed Al-Sobki for the post sessions, one on the conflict and the other on the supply chain resilience, and also the recommendations provided by UNHCR, WHO, Civil Society Support Fund, Egypt Healthcare Authority, Egypt Red Crescent, and their recommendations actually was very important because they addressed, we discussed a lot of challenges raised during receiving a lot of displaced population from different countries, especially in the Middle East. And you know, the location of Egypt is very crucial, and the support from Egypt for the different neighbors very crucial when it comes to Sudan, Libya, and Gaza. So the experience of the UN agencies, as well as the experience of the public authorities in Egypt and the private sector, very important. And we appreciate the commitment of the government of Egypt and the international partners to prioritizing the health and well-being for the vulnerable population and displaced people. So this type of roundtables from time to time can coordinate the efforts between the stakeholders. And we discovered during our session that there is a lot of duplication, and we need for more integration and more practical solutions and more resilient solutions. So this was some remarks on the roundtable that had been placed in Egypt on the mass displacement and in conflict. But when we come to your question, Shaza, about the innovative solutions for the displaced people, you know, when we are talking about the displaced population, it's not only the external who go to different countries, but the internal displacement also very important. And the role of the neighbor countries and the world towards those people very important. When we are talking about the healthcare, it's not the healthcare in terms of medicines and clinics, but the housing, the water safety, the environment, the mental health for those people. It's very important to work together, not only the health providers and the UN agencies who are working on healthcare, but the integration between different types of agencies that can improve the health at the end. So the role of the different countries is to provide the internal displaced people with the essential needs, and providing them with some solutions, innovative solutions, like digital solutions, like mobile clinics, like setting the priorities with the local people there when it comes to the vaccination of the children and the motherhood and the antenatal care, and all these very important challenges. But when it comes to the external displacement, or the people who go to different countries, like in Egypt, for example, when we received more than 15, I would say 20 millions in less than 5 years from different countries. But the model of Egypt is, I think, is the right model when the government engaged the people within the communities, not isolated in camps like the different countries. So engaging them in the community and providing them with the basic needs as Egyptians will protect the Egyptians. So all the national programs, the public initiatives, the antenatal care program, the motherhood and childhood programs, for free for all, even the non-Egyptians, refugees or the displaced people. So even the different models or financing models, we are talking on sustainable models. Egypt now work to set an example for the sustainable financial model, when a mixed model between the health insurance, the civil society support fund, the UNHCR, and different donors or international aid with the government to set programs or fixed programs for healthcare for the refugees and the displaced people. The identification of the refugees is very important from the beginning. The accessibility of the care, the culture sensitive services, the using and of the health workers and community workers from refugees and the people, displaced people, so we can use from them some community health providers and some health workers to engage in the health system of the country to provide more resilient and sustainable services. So Egypt model in hosting and in engaging in the community, the refugees and the asylum seekers, very good example for different countries. And again, the engagement within the community and using the same facilities and same insurance system and same basic primary care services, very important. And I think this is example of Egypt. We can build on this example and improve more and more with more cooperation between the different UN agencies and the different fund aid, international aid. Thank you.
Thank you so much, Dr. Hala. Now I'll take from Dr. Hala's insightful contribution and address Dr. Ahmed Al-Subki. So, as you know, ensuring uninterrupted healthcare delivery during crisis is a crucial matter. So, from your vantage point as the chairman of Healthcare Authority, what are the primary challenges that you see, and how collaboratively can we address these challenges?
Thank you so much, Dr. Shaza. And first of all, I'd like to thank you so much for having me in this very prestigious panel with the eminent leaders from Egypt and also from India and virtually from everywhere. Thank you so much for that. And actually, before having the response to your very valuable question, I'd like also to thank Dr. Hala Zaid for her insights and her support for the hosting of the first roundtable in Egypt Healthcare Authority in two topics which are very important. First one, the resilience and the displacement challenges, and for sure supply chain and logistic issues. I think those are the main challenges now we are facing in the world, especially in the MENA region, as you see in because of the conflicts in Gaza and also in Syria, in Yemen, in a lot of in Libya for sure. So all of these challenges are facing now are faced now by a country like Egypt and Turkey and some countries. I can call them the host countries. And back again to your question. So we have like two categories of these challenges. So the first one faced by the host communities, and second one faced by the displaced communities. So if we talk about the challenges faced by the host communities like Egypt and like Turkey, as I said, so the first is the infrastructure strains and also the pressure on the capacity and the capability to have more and more influx from the patients from the displaced communities to be served in the host communities. And in this regard, I can say that Egypt already played very important role to contain and to maintain the basic healthcare services for some refugees from Gaza, Palestinian people, and also from Syria, from Yemen, from Libya. And in this regard, we would thank His Excellency the Minister of Health, and for sure the Prime Minister and His Excellency the President for having the instructions to contain and maintain this basic humanitarian aids and also basic services for all of these refugees. And for sure, the second and most important challenge, it's the financial challenge, because we are talking about a lot of patients suffering from war injuries, and for sure, complicated cases, especially cancer patients. So all of this patient, I think from my point of view, the cost of treatment and management of these cases is very high compared to the normal cases or the ordinary cases. So the financial burden and the financial sustainability to maintain the services for all of this patient, I think it's very crucial to be considered again. And for sure, the shortage of the healthcare workforce in a country like Egypt, as you know, the density of doctors compared to the population, we have like 1.4 doctors or healthcare workforce to 10,000 population. So the ratio we have some challenges regarding having the full coverage of all the populations in Egypt with the limited number of doctors and nurses and healthcare workforce. Especially we are suffering from brain drain, because as you see, and India for sure suffering from brain drain, especially when it comes to healthcare workforce. Not only the shortage, but also the burning out, because we are receiving a lot of miserable cases from Gaza, from Syria, from Yemen, from Libya. All of these cases are very complicated, and for sure the war injuries, as I said. So the pressure, the psychological pressure on the healthcare workforce may lead to the burning out of them. And we are trying to have some measures and some strategies to elevate and to enhance the morale and the spirit of our healthcare workforce to face this very important challenge. And last but not least, the medication. And as you know, the supply chain and logistics are very important issues when it comes to healthcare industry. So the medication is limited. The consumables for the surgeries are limited. So we have to consider also this scarcity of resources when it comes to the medication and consumables. And then refer to the second very important category, which is the displaced communities. And from my point of view, I can say that the first and the most important challenge is the violence against the healthcare facilities and healthcare workforce. And we can see this in Ukraine, we can see this in Gaza, bombing of the hospitals, targeting the healthcare workforce, and this is not a humanitarian act. And for sure, it's like very important challenge to be addressed, not only for the countries but also for the international community, to make sure that it's forbidden to, or it's not allowed to bomb the hospitals and to target the healthcare workforce. And for sure that the mental and psychological health of the patients and also the healthcare workforce and healthcare providers inside this environment, very challenging environment with insecurity, with bombing, as I said. So it's very important also to address the psychological and the mental aspects of our healthcare workforce again. And cutting off the supply chain and the cycle and the processes of the logistics to have the vaccines, and this is very important. So we can see this in Gaza and in Ukraine for sure. The vaccination challenges and deprived population, especially the childs under 5, from the basic vaccinations for polio and for the diseases prevented by the vaccinations. And for sure, this led to outbreaks, and we already have seen this in Gaza. We already have seen this in Syria and in Yemen, in Libya, and in Ukraine. So the vaccination is like red line, because at the end of the day, we live in one world. So there is no borders when it comes to the outbreaks. So again, it's like responsibility of WHO and the international community to save the vaccinations and the basic interventions to childs and for sure to the vulnerable groups of population. So after mentioning all of these challenges, so the question is how we can face all of these challenges. And I can see this, that with the platform like MENA region chapter, we already launched today for the GLC, for health system resilience. I think this is one of the main and one of the most important steps we have to take to face the challenges like the displacement and refugees and the forced migration. So with these platforms, we can exchange the knowledge, we can exchange the experience, we can exchange the lessons learned, maybe also to enhance funding of some very basic interventions like affordable vaccination and also the primary healthcare in these deprived areas. And for sure, and I would like here to thank Dr. Sohail in his presentation. He already said the tool of WHO to face the displacement, and also how we can also innovate some interventions when it comes to the measures and the strategies using mobile clinics, using mobile services, and for sure the virtual services. And we can make use of the technology and AI to serve those people in the deprived areas and marginalized areas with teleconsultation using telemedicine, and for sure with virtual services like telepathology, teleradiology, and all the virtual services we can do this. And already in Egypt now we are prepare ourselves for this. So we already established the first virtual hospital in Canal region, and one of the main functions of this hospital is to serve the underserved community and the deprived communities in Gaza and in Palestine. So again, to innovate measures like mobile clinics and mobile healthcare services, and also using the technology, I think this will leverage the capability of the host communities and the host countries to serve more and more people in their places without displacement like in Gaza. For sure, addressing this and addressing all of these challenges to the international community, to the funding agencies, to the WHO and UN agencies is very important and highly recommended to take attention and also to pay attention for this very important crisis. So I think after the pandemics and after COVID-19, so the first ranked important challenge is now the displacement and refugees and forced migration. So we have to pay attention of this. We have again to take international or to take actions from the international concept. And again, we have to support non-state actors like Access International, like the platforms like GLC to do their jobs to support the governments in hosting countries and also in the displacement countries. Again, thank you so much for having me in this. And I'd like for sure to thank Access International for giving me this opportunity and this privilege to say some insights from the ground from Egypt. Thank you so much.
Thank you, Dr. Ahmed. And please allow me to reaffirm on a very valuable piece of your contribution related to the mental health and well-being of the service providers, whether they are in the host communities or the frontliners. So this is a very important piece of your contribution because this is usually overlooked. And I'll take from that and address Dr. Malarao with the next question, which I see also from a health equity perspective. And it's usually also overlooked when we discuss hot topics like conflicts, emergency response. The health equity usually gets overlooked. So I want to know from your expertise, what targeted interventions can be implemented to ensure that the healthcare needs of vulnerable population in general, whether they are women, children, persons with disabilities, elderly, are taken care and prioritized in the conflict settings?
Well, thank you so much for a really good question. Again, I've pulled out, because of my particular interest in gender equity, I pulled out some data from the published literature, and I'll refer to that. But I want to say something about my personal experience because, in the UK, we are in some ways shielded from some of the things that you're seeing in Egypt and in mainland Europe and in Africa, or also in Southeast Asia. But as a young public health physician, I did have such an occasion when I had to look after refugees when Yugoslavia broke up, and a huge number of refugees fled to the UK. And we knew this was happening. And I was a director of public health in charge of a district, which was not a receiving district because that wasn't where the ferries were coming in. And there was a decision made that, the receiving county where the ferry terminals were should not be expected to take the entire burden of this new influx of refugees. And there was a fairly rapid decision made to disperse them in groups, family groups and so on, to many of the other districts, neighboring districts. So one day I just found myself with about 48 hours notice being told, you're the director of public health and you will now receive these 500 people who are arriving. So the social services department, the health department simply had to gear itself up to look after these people. This was in the pre-internet era. If you remember, this happened in the 1990s. So with little time to prepare, little time to try and imagine what the issues might be, I found myself having to look after them. And this is this, and of course, typically what we know from UN reports is that we have about 100 million people currently displaced globally, with adolescent girls and young women, along with children, bearing the disproportionate burden. So the bulk of the refugees across the world are women and children. These vulnerable groups face significant challenges, including, as you said, Your Excellency, limited access to healthcare, shelter, and protection. When they arrived, these refugees arrived, they didn't have clothes, they didn't have shoes, they didn't have warm, coats. They didn't have anywhere to live. And so those things had to be taken care of even before we could assess them for their health risks. And you're absolutely right. There is some literature, limited literature, about what might be a kind of a checklist receiving host communities might find useful when receiving refugees, in particular for women and children, the more vulnerable groups. But there is precious little to be found about people with disability or indigenous communities who may be who may be minority communities within countries that are often the first to find themselves at risk in having to flee war, especially internal, civil war that might happen. Very little to show you what to do. I found, and I can confirm, that there are severe reproductive health challenges, and Your Excellency, you mentioned that too. Globally, it's estimated that 60% of preventable maternal deaths occur in conflict-affected settings, where maternal mortality rates can be twice as high as those in stable regions. The destruction of health facilities, mass displacement, and heightened risks of sexual and gender-based violence further reduce access to essential sexual and reproductive health services. And I saw that, because the women were frightened and they didn't want to talk to me. And again, it took trauma-informed interpreters to be able to tease out of them what the issues were. And it turned out there was an extraordinary level of gender-based violence that they had endured before actually finding themselves in the United Kingdom. There's limited access to skilled birth attendants, emergency obstetric care, contraceptive services, all of that exacerbating maternal and neonatal mortality rates. So, and children come with severe malnutrition because they may have been traveling for well up to weeks, months before they finally arrive in a safe haven. Preventable diseases, you mentioned them, Dr. Ahmed, and developmental delays, because as a consequence of the trauma that these children have endured and the sights they have seen, which I think it's almost for us hard to imagine. So the targeted solutions have to be comprehensive and take account of the entire burden of physical and, as you mentioned, mental health traumas that these refugees have endured, whether they're being provided in their own country or in another safe country to which they have fled. And they may have to be provided at very short notice. And one of the things that I came across was actually getting healthcare workers from among the refugees to give them some form of temporary registration, rapid e-training, in order to provide some of the things within their communities and their camps or whatever has been set up. But the temporary accommodation that's been provided for those communities. I think another thing is establishing really good communication with them. I found that we had an interpreter who we hadn't realized they weren't prepared to talk to, because that person didn't come from the community. In fact, they had the interpreter came from the community they were fleeing, and of course we didn't know that. And so one has to be very careful about who you entrust with providing that communication and interpretation services to establish that trust and confidence with the community. So I'm going to stop there in the interest of time. But I think it's about letting the community inform you as to what they want, but recognizing that it's going to take time, it's going to take affection, it's going to take respect, humanity. They need to know that when you go in there to provide that, you do it out of a deep respect and concern and sympathy with what they've gone through. And then and that's got to be the basis of that trusting relationship you can establish to begin providing the physical and mental health services they need. So thank you. Actually, can I mention one other thing? I came across peacekeeping missions can increase the risk of vulnerability and gender-based violence within some of these conflict communities. And so that's something that requires us to sensitize and train and inform and bring in right levels of governance within even peacekeeping missions that go out there allegedly to keep the peace and provide some kind of safe services, but it might sometimes end up exacerbating the problem rather than addressing it. Thank you.
Thank you so much, Professor Rao. Now, I also want to confirm on the importance of, from again a health equity perspective, the importance of taking into consideration a lot of social interventions that needs to be taken care of in order to eventually have an equitable healthcare access. And this actually takes me to my question to Dr. Ahmed Saada. Hi, Dr. Ahmed. Are we
Hello,
audible?
good afternoon from...
Can you hear us well?
Yes.
Perfect.
You hear?
Yes, we can hear you. So, Dr. Ahmed, as you know, and everyone in the conference room knows, that civil society plays a pivotal role in advocating for healthcare access, and it also lays a lot of social interventions that eventually again enhance the health outcomes of displaced population. So in your role as the executive director of the Civil Society Fund in Egypt, how can you see that civil society be empowered enough to effectively facilitate the healthcare access for displaced populations?
First of all, thank you so much for inviting me to this distinguished panel. And I would like to second Her Excellency Dr. Hala for the need of the coffee at the day of Ramadan. And it's a very long day, and we need a lot of caffeine as well. I would like also to thank Dr. Ahmed Sobki and the distinguished panel for those really important insights and actually engaging in such important topic in such positive manner. If I may share a screen, if it is okay to share some slides. Okay.
Please go ahead.
Okay. I'll try to share the screen, but meanwhile, I would like to also say that it is my honor that I had the privilege to study in New Delhi University once before. I studied the human security in 2017, and it was a very important step in my life. Please let me know if the screen is there and the slides is appearing.
We can see it very well. We can see it very well, Doctor. Go ahead.
Thank you so much. So I would like first to give a brief about the civil society organizations. Approximately 36,000 NGOs or civil society organizations registered in Egypt according to the new law. So as a historical or an overview about the civil society organizations, the civil society organizations are very diverse in Egypt. So a wide array of organizations addressing diverse needs of the healthcare, education, environmental protection, human rights advocacy, different topics. That's a very vibrant and active and rich civil society in Egypt. Historically, the civil society is deeply actually rooted in our history, shaped by periods of both expansion and restrictions as well. Understanding the context of the civil society organizations and the legal context is actually crucial to understand how civil society organizations can actively engage in supporting the healthcare systems in Egypt. Based on this very wide history, understanding that we have a law now that was issued into 2019. We call this the golden law for the civil society organizations. Actually, it regulates the establishment of the civil society organizations, outlining the registration requirement, etc., how to fundraise, etc., and some executive regulations that followed this law, which allowed more independent civil society organizations and also allowed for international cooperation with the civil society organization at wide scale. The Civil Society Support Fund is actually a national public authority that is established according to the law of civil society organizations in 2019. It was activated in 2022 with a vision of an independent, empowered, and capable civil society that effectively partner with the state to achieve the Sustainable Development Goals, Egypt Vision 2030, and respond to the urgent humanitarian and relief challenges. With a mission to enhance the work of the civil society and the values of positive citizenship. And this is really important for us. We focus on positive citizenship and also across our programs by contributing to the creation of an enabling and supporting ecosystem for the civil society institutions and organizations. Our values, accountability, agility is really important for us. Accountability towards funding, accountability towards affected population, impact. We are not only planning for programs, but also impacting how the impact can sustain transparency and sustainability. We have a very simple granting criteria. So I'm giving just a brief about the civil society, just to understand how we can also understand the context of the civil society in Egypt. So we have a very simple eligibility criteria with a very transparent application process, with a very open and transparent selection criteria as well. Some challenges we have, some related to bureaucracy, how we can support the civil society organizations to modernize its systems, the digital transformation, capacity building, capacity sharing. So we are working on addressing those challenges through different programs, and also to ensure transparency that we have a very strict financial management systems that we put in place from the first day. So as a key strategic imperatives for the Civil Society Support Fund, CSF, as we abbreviate it, so the institutional governance is our first strategic imperative, financial sustainability, sustainable partnerships, capacity building, and governance of project funding. We have a very clear theory of change. So we say if that exists a national entity like CSF, characterized by institutional excellence and the principles of good governance, actively contributes to creating an enabling and effective regulated environment for civil society work, then civil society will be able to contribute effectively, efficiently, and independently to achieve the national objectives of development, social justice, and climate justice, as well as effectively responding to humanitarian and emergency needs. So here's come to the points that you have raised, Dr. Shaza. So empowering civil society organizations is also to improve the adaptability of healthcare facilities and healthcare systems at large. It requires actually providing not only financial resources, but also technical support and capacity building that enables civil society to develop and design and implement innovative and responsive programs. So In terms of the infrastructure adaptability, we have recorded and we understand that offering grants and technical assistance to CSOs, civil society organizations focused on transforming existing healthcare facilities and including supporting as well of development of modular and mobile healthcare centers that can quickly be configured to meet emergency needs is really crucial. So from this point, I really would like to emphasize on that we need to plan ahead if we would like to engage civil society organizations effectively during crises. So we need to dedicate funding and technical assistance for civil society organizations to have this capacity at scale, not only for some specialized organizations in a specific location. So investing resources to retrofit facilities and to reduce flexible designs that allow the rapid adaptation during crisis is also really important. So this is a quality that we would like to transfer and to share with the civil society organizations. So healthcare access to vulnerable populations, which is really important. So communities are the nearest point to the affected populations. Local communities and local civil society organizations are really crucial in the design of the emergency response and preparedness system. So recognizing the critical need for health services amongst the vulnerable groups, channeling funding towards civil society organizations that develop targeted outreach initiative is really important. So building those capacities at the peripheral level is really important during peacetime to make sure that during crisis we can build on those capacities. So investing in capacities, so civil society organizations that implement mobile clinics, community-based health programs, ensuring that the timely response of those arms of the implementation for the good of the vulnerable populations receive timely and cultural sensitive as well. So we receive refugees and migrants from neighboring countries. So we need also to understand the cultural sensitivity and to get the civil society ready and fit for responding in such context. Supporting policies and structures, investing in the strengthening and the policy advocacy capacities of civil society organizations and their relationship and partnership also with the private sector is really important to triangulate the picture of how you would like also to support policies and building structures of the healthcare systems in Egypt. Sustainable funding, which is really important. I have highlighted that also during the discussions that Her Excellency mentioned in Cairo. So we need to make sure that there are different layers of funding streams for civil society organizations. Developing multi-year grants that allow the sustainable programming for civil society organizations, giving seed funds for the newly established civil society organizations to let them grow and flourish, mechanisms that promote diversified funding streams. For example, crowd fundraising. I'm going to highlight that in a bit. So the financial support not only ensures the initiation of innovative projects, but also helps civil society organizations to develop their independent strategies for long-term sustainability that allows them to partner with local and international donors independently, that allow also for the community to be stronger and more sustainable. Emergency response, which is really important. This is a priority that we work on the preparedness, but the preparedness is also need to be granted by funding the development and implementation of comprehensive emergency response plans among civil society organizations, to include them at the design level, at the capacity building level, and also the implementation level. With the access to those funding, civil society organizations can conduct trainings at the local level, so they can train volunteers at the village level or at the suburb level. So that will allow them to rapidly respond to the crises and be an implementing arm for the relief and aid programs during crises. So I'm going to highlight a little bit about how we are now working on supporting the civil society organizations from a digital point of view that can allow us to help civil society organizations to grow and to be more independent and to be engaging more in the healthcare preparedness during emergencies. So this is a design of our digital platform that is going to be launched in a couple of months. This is the digital platform of the Civil Site Support Fund that is actually linked to the national registry and database of the civil society organizations. So we have direct connections with the Ministry of Social Solidarity and the database of the civil society organizations. So we understand that those civil society organizations are regulated, they are working, if there is any updates on their information, we get that immediately. We have a strong CRM system, the Customer Relations Management System, and also ERP system that controls all the activities of the fund, financial, procurement, HR, warehousing, everything related to those, to our core activities, to our operational activities that are controlled by a strong management system. And we provided two solutions for the civil society organizations. Donation and campaigns management systems that is going to be launched to allow civil society organizations to host, to allow us to host their campaigns and to advocate and to market for their donations as well. And also we are going to launch a very strong grant management system that will allow Civil Society Support Fund to offer grants for civil society organizations digitally, so they can apply for those grants very openly and also with that very transparent systems. Also, at the strategy level, we have a very strong strategy management system that allow our boards to follow our strategies, and also how we are integrating our, how we are feeding it into our government plans, as well as the Egypt Vision 2030, also, and the UN SDGs. And we have a very strong as well data management system for our for the beneficiaries, that the end beneficiaries, that those are getting support from our systems. So from this platforms, we are also going to integrate with the National Volunteers Platform for of the Ministry of Social Solidarity. The fund is supporting the establishment and the operations of such a platform. It's going to be a very important platform for all volunteers in Egypt. And also we are running an emergency response management system also for the Ministry of Social Solidarity that allows a very effective and organize the response system for during crises. I would like to stop here, and I'm really happy to answer any questions. And thank you so much for this important opportunity. Thank you so much.
Thank you so much, Dr. Ahmed. I'll specifically touch upon the policy side, because you've mentioned that the regulating policies are really important. I will also say that policy overarches the activities being done by the different stakeholders in times of conflicts, and it actually strategizes the different initiatives carried out across all the players. So this might take me to Dr. Jacob Aram. Hi, Dr. Jacob.
Hi, Dr. Shaza.
It's a pleasure having you in this panel. So my question to you, as you know, the policy initiatives are essential for integrating health services for the displaced populations. What, in your mind, are the strategic policy initiatives do you believe are critical for effectively upholding the rights of the displaced populations?
Okay, thank you so much for this question, Dr. Shazan, and thank you all the esteemed panelists for their insights and points. And also a great thank you for the Global Learning Collaborative and Access Health International that are organizing this. So what I would like to talk about in terms of important initiatives, I think the key word is inclusion. And I would like to follow up and complement to what Her Excellency Dr. Hala Zaid was saying about Egypt, and how Egypt have been very generous in offering a lot of healthcare to refugees and forcibly displaced people in Egypt. I'm going to continue to talk about Egypt because this is the where I work right now, and it's also, I think, an example what the more and more the typical refugee situation is. It's a middle-income country. It's refugees that come from neighboring countries. It's a protracted situation with refugees that have been there for a long period of time. You know, the old situation with the refugees that are put aside in camps with parallel systems that the government of the country is not taking any responsibility for. This is, I hope and believe, is a bygone era. And what we see now is refugees that are living mixed with the host population and are trying to survive on more or less equal conditions. But so the key here is how to include them in society. And so it's not, even if this is focusing on health, but I think inclusion has to go further than that. And I'm going to talk much about financial inclusion. That refugees, I mean, most health system, you need to be, there are financial constraints. And if a refugee gets access to the local labor market, you have access to I mean, all the rights that a local person has in terms of the right to work and the right to make a living. Also, the same rights to open bank accounts, etc. You will have an opportunity for the refugees to get their own livelihoods and also to contribute to the society where they are in. And there's a need to get away from the idea that the refugees are mostly a burden for the host country, but it's also a generation of income for the country, and in a very past point of view. I would like to give as an example that now when the Sudanese refugees entered into Egypt, one of the first effects that you could see was that prices on rents went up in many neighborhoods in Cairo. Because you had a much higher demand on for housing. So a lot of people rented out their houses, but to much higher prices than before. And the refugees were paying for this. And you can say, well, these are just money that are circulating locally. It's nothing that goes into the governmental, to the national treasury, or that can be used in healthcare. But the people that are getting the rent are using this money. They are buying products in shops, and maybe these shops do not pay tax either, because they have a very big informal sector in the Egyptian economy. But eventually, because these shops might buy their products from a factory or from an importer, a company that has been importing the goods, and they pay taxes. So a lot of them, the money that refugees, is like they are actually expanding the economy, and there is reason to believe that there's a they have the same rights, or should have the same rights as the local population in terms of access to healthcare. And one of the problems in Egypt for refugees is that even though they have access to all the basic services, they are not included in any of the national financial protection mechanisms when it comes to advanced healthcare. And my argument would be that they should have that. But there are a world of different other factors to take into consideration. But increased inclusion, not only in the health system, but in society at large, I think is key to improve the situation and improve the health situation for refugees. Now, Egypt is on a very good path. Right now, they are introducing a new law, the new asylum law, where they are going to take the responsibility for the refugees that are coming into Egypt, including registration and so on, that UNHCR has been providing before. And I think this is an excellent step, because that means that the Egyptian government is going to be much more aware of the refugees as a group. They are going to know who they are, where they live, their income, their household sizes, and so on. And that is going to make it much easier for them to see refugees as a part of the rest of the population that they are responsible for, and open up doors for further inclusion in everything that I have mentioned. And I think just to finish, this approach, I think, opens up a lot of doors when it comes to the international community, and possibility for financial support from developmental organization. And you can see this in other countries like Jordan and Turkey that have taken this step to include refugees in the grand scale in their national systems. And there you see that instead of having organizations like UNHCR and IOM that are being supported and then support the refugees and migrants, support goes straight to the government. And I think this is a more viable way to work with providing health to refugees. Yeah, I'm looking forward to see the path that Egypt is going to take in this respect. So thank you.
Thank you so much, Dr. Jacob. And to conclude your very insightful contribution, it is then the inclusive, comprehensive strategies and policies that actually looks beyond health. It looks more on the social vertical, housing, financial inclusion, financial assistance, etc. So eventually, these are the social determinants of health, and they will definitely enhance the health outcomes at the end. Thank you so much, Doctor. Thank you so much, dear panelists. I will not conclude because I know we're short of time, and I think that will be finally there will be recommendations for all the sessions.